Dental bridge, fixed replacement anchored to abutments or implants, not removable. Next, why it matters. 36 million Americans lack all teeth, driving demand for fixed bridges and implants nationwide today. These are key bridge terms: pontic, abutment, retainer, connector, ear, span, and unit. Next, a simple breakdown. Bridge parts. Pontic replaces tooth. Abutment support. Retainers secure. Connectors distribute forces. Next, clinical indication. Bridge suits short spans with strong support and stable bite, especially when implants are unsuitable. Quick contrast. Surgery, preparation, and time to restore vary across bridges, implants, and partial dentures. Treatment time varies. Bridges are quickest. Implants take months. Next, why closing gaps truly matter. Leave a gap. Teeth drift, supra-erupt, bite strains and food traps. Alveolar ridge resorbs quickly. Next, we shift from overview to mechanics. What bridges are, how bridges function, and aftercare. Deflection scales with span cubed. Two-tooth spans amplify bending. Non-rigid connectors at piers reduce stress. Units tally abutments and pontics. Spans map site and extent. Retention groups supports. History next. From gold to Buonocore's acid etch and Maryland bridges to KD cam zirconia, today's types follow next. Here are 4 dental bridge types: traditional, cantilever, resin bonded, and implant supported. Next, traditional details coming. Conventional 3-unit bridge, axial and occlusal reductions, material matched margins, strong abutments, high survival. Next, cantilever, used selectively for small anterior spaces with careful occlusion, higher abutment risk. Next, resin bonded. Maryland bridges conserve enamel. Success depends on bonding. Debonding is the main risk. Next, implant. 2 implants support 3 teeth, spare neighbors, preserve bone. Surgical healing needed. Selection criteria next. Quick selection snapshot. Traditional FPD, resin-bonded, and implant-supported bridges. Next, we present comparative survival rates. At 5 years, all perform well. By 10, implant-supported notably leads, resin-bonded declines. Next, complication. Over 10 years, biologic issues dominate FPDs. Implants show similar technical, variable biologic. Next, material. Common bridges span metal, ceramic, and composite options. Next, we compare key properties across types. PFM is proven and strong. Minor aesthetic or allergy drawbacks. Smaller connectors. Zirconia comes next. Zirconia bridges deliver high strength. Monolithic reduces chipping. Optimize connectors and bonding. Next, lithium disilicate. Lithium disilicate suits aesthetic. Short spans requiring adhesive bonding. Reserve long posterior bridges for stronger options. Choose abutments with healthy support, favorable anatomy, manageable risk, and function. Then consider Ante's Law. Ante's Law guides abutment selection. Today, a clinical reference within comprehensive diagnosis and treatment planning. Diagnostics complete. Align aesthetics and function. Then plan preparation, temporization, and final bridge delivery. Bridge workflow. Prepare abutments, records, provisional, final, try-in, cement, verify. Next, preparation parameters affecting longevity. Reduce as planned, preserve tooth biology, and choose correct margins. Next, impressions or digital scan. Use PVS impressions or digital scanners to capture bites and margins with retraction. Next, provisionals. Temporary bridges protect teeth, maintain occlusion and contacts, shape tissues with ovate pontics, refine phonetic. PFM wax-up, cast, layer porcelain, zirconia or S2, KD cam and center. Verify design and shade. Before cementation, confirm fit, contacts, occlusion, pontic clearance, aesthetics, screw access, and radiographs as needed. Adhesive resin bonds strongest, RMGI or GI acceptable, zirconia, metal need MDP, lithium disilicate HF plus Ilane. At 10 years implants lead, conventional lasts 10 to 15. Next, chewing and comfort outcome. Fixed bridges restore near natural chewing, offering comfort and bite force. Phonetic support boosts confidence. Designed for emergence, clear sibilance, and smile harmony. Next, we'll review common complications with frequency. Common complications and approximate incidences shown. Next, we explain biologic risk factors and mechanisms briefly. Biologic risks. Caries with xerostomia, poor plaque control, deep margins, diabetes, smoking, and pontic impaction. Long spans, undersized connectors, bruxism, and cantilevers increase failure risk. Next, evidence-based bridge hygiene strategy. Underponic cleaning uses threaded floss, interdental brushes, plus oral irrigators to reduce plaque, bleeding. Recall next. Plan individualized 6-month recalls. Monitor margins, caries risk, occlusion, pontics, implants, bite guards. Costs next. Quick snapshot. Bridges partially covered after deductible. Implant coverage varies. Mind replacement and waiting limit. Conventional 3-unit bridges restore function and aesthetics without surgery. Strong 10-year survival. Next, matching scenario. Quick fit recap. Traditional, cantilever, resin bonded, implant supported. Next, innovations improving clinical outcomes and workflows soon. New materials, adhesion, and digital workflows elevate bridges. Next, Pontic design secures lasting success and aesthetic. Match Pontic choice to site, tissue, and hygiene. Favor gentle tissue contact. Next, comparison snapshot. Quick snapshot. Briefly comparing prep invasiveness, survival, timeline, and cost across bridges versus implants today. In short, bridges suit crown neighbors. Implants preserve bone and handle long spans well overall. Dental bridges deliver natural function when case selection, design, fabrication, and daily hygiene are meticulous.